Welcome back to the podcast. In this episode, we're going to be speaking with Phil Cowburn about the 10 Second Triage Tool in action. So what I wanted to do in the episode is really just delve into the 10 Second Triage Tool to understand how well it performs in simulation, but also is an analog really for real life. So we're going to explore the development and impact of the major incident triage tools, so the MITT and the TST. And what we're going to do is really dig into just how it's transforming both triage and indeed emergency response to major incidents. We're also going to look at how and where and when it might apply for training for responders and indeed some of the real world applications. So joining us today is Dr. Phil Cowburn. He is a consultant in emergency medicine. He's also the medical director for Southwest Ambulance Service and the co-author for the 10 Second Triage Tool in mass casualty incidents. Phil is a consultant in emergency medicine working at both trusts in Bristol, but he's also the co-founder of Great Western Air Ambulance Service in the UK. So he's been involved for over a decade in pre-hospital care and indeed is the medical advisor for the National Ambulance Resilience Unit. Phil, welcome to the podcast.
Thank you very much for inviting me, Owen.
I've spoken with Claire Park on the podcast and just sort of framed the TST, but just if you could maybe initially just speak to the driver for changes in triage tools and indeed from your perspective, how the TST came about.
Yes, thanks. So there was a number of us working under a task and finish working group from NHS England looking at revising what was our current triage tools, which at that stage was the NASMED NARU SIV and also the triage sort. And we were looking to take evidence-based practice forward to try and revise those. Myself and Claire Park had been working for quite a bit of time on considering quicker triage tools that could be used in the hands of lay responders as well as clinicians. And we were also very concerned around the cognitive load that you will undergo in an incident like this. You know, the bandwidth of responders will be markedly stretched during something, you know, the sight, the sound, the smell, and everything that is going on around them on the worst day of their life. Are they going to be able to do the things that when you're sat in a classroom may make absolute sense? So we were working on that, and there was a great group of academics and pre-hospital practitioners involved in that. And we said, but hang on, what we want is something that is very quick and very easy and just focuses on those immediate life-saving interventions that we know will make a difference in that very early stage. And the research that Claire is doing at the moment and evidence that we've had from a number of incidents, we know that the things that will kill you in that early stage are loss of airway and severe bleeding. And if we could just have something that purely focused on those. So Claire and I had been working, we both work for different police forces, and we'd been looking at options for, you know, delivering life-saving interventions and prioritising patients in more tactical situations. So we'd got some models on that. And when we came to the first iteration of what then turned into the major incident triage tool, working with Jamie Vassallo in his stuff he'd done with MPTT 24, we devised this tool and we put it through a fairly extensive field test. And this was a series of mock major incidents, and we had a range of paramedic practitioners, right from students through newly qualified to experienced, through heart critical care practitioners, and we put them into these environments and got them to use these tools. And we were looking at both qualitative data, you know, how accurate were they, how long did it take, also more quantitative data looking at that, also qualitative stuff like how did it feel, how easy was it to use, and taking feedback. So when we tested these tools, we just saw everything that we had feared. People cannot count pulses, respiratory rates, do the arithmetic. No one's wearing a watch anymore because we're bare below the elbows, and just the burden of the physiological criteria just exceed the bandwidth that any responder has at that time. And this was just in a simulated exercise, so it wasn't even as stark as the real thing. So we really went back to try and look at options for triage tools that didn't use any physiological variables to try and take out that burden on people, but to really focus on the life-saving interventions. I'd been working on a tool with my police officers which was very straightforward, which was just kind of walking, talking, not breathing. And Claire had been working on one with Metropolitan Police, which also highlighted penetrating torso injury, which we know can be related to incompressible hemorrhage that cannot be dealt with, and to prioritise those patients. So we did a little bit of a smash the two tools together, and we came up with the tool that is now known as 10 Second Triage Tool. And it's designed to be very quick and dirty. It's not designed to be the most sensitive, the most specific. It is just designed to be put in the hands of as many responders as possible to get those life-saving interventions done, have a rough idea on the prioritization of those patients. And this very much aligned with the ongoing, at the time, Manchester Arena inquiry, looking at the tragedy from the City Room, and realising that when you have a large number of patients and just a very few responders at that initial stage, you want someone very quickly to go round, save a few lives, and then get an idea on the enormity of what is going on. So that's kind of how we came up with the idea of what turned into 10 Second Triage. There was another bit that we really considered, and this has become more and more important to me as I've discussed this with a lot of responders that have been at major incidents such as Manchester, Borough Market, London Bridge. And that is that on the previous tools, you just opened the airway, and if there was no breathing, you counted them as dead. Now, in those early stages, you don't know the enormity of the scene. There may only be 5 or 10 people there. So consigning somebody that doesn't appear to be breathing as dead, when we know that the survival rates from traumatic cardiac arrest, if really aggressively managed, are certainly significant. And of course, those responders have to make that decision in a split second. They then have to live with that decision, and they have to go through the public inquiry where that decision will be scrutinised in front of friends, family, and coroner KCs. So we were keen to put in a new category of not breathing, which is saying, we're not saying you're dead yet. You may well turn out to be dead. But what we want to do is just put you in a position of safety, roll you in the recovery position. If resources allow, and there's people wanting to deliver CPR, we won't get in the way of that. And that will allow us to move through the entire casualty chain and then come back to them once the dust has settled a bit, when you have that cognitive ability to properly rationalise that decision. And what's been very moving is speaking to a couple of responders from big incidents that say, I wish I had that, because I was really struggling to make that decision in that split second. Is this patient dead or not? Are they viable? So I think not only is that great for patients, it's great for responders, but it then truly opens up this tool to non-clinical responders who wouldn't normally be allowed to just say somebody is dead. So all of a sudden, 10-second triage in the hands of multiple emergency services responders becomes a massive force multiplier, and means that a lot of patients can be triaged very quickly.
I think that's such a fundamental point, Phil, around the fact it's almost a tool which has universal kind of application really across the services. And like you said, what it does is it empowers other individuals, other police force, fire brigade, whoever, to utilize the tool. And it's a common architecture, common signature, and then common understanding that that's the end result. And like you said, quick and dirty, which is actually what it needs to be. And you just said something which is really interesting, and I'm going to press you on it slightly, not press you on it, but just almost violently agree with you. But that what we negate in major incidents is this really profound sense of human factors. It's your own physiology is through the roof. Your heart is in
Yeah.
your mouth. Your own respiratory rate is through the roof, and actually making any kind of semblance of big decision and indeed sequential decision and dynamic decision in that moment is so difficult actually. And one of the things you said, just simplifying things, it really is such a key to adoption and indeed compliance to the tool, because I think one thing we were seeing as an analog was we were seeing a lot of missed VF in cardiac arrest, and we were like, why are clinicians missing ventricular fibrillation? But actually, if you look at a cardiac arrest in a public domain or otherwise, it's frenetic, and there's so many human factors, and it's only when you've been there, and it's only when you've been in a major incident do you get the enormity of the human factors involved in these situations. So I guess my question on the back of that is, have you seen an increase in compliance and effectiveness of the tool in testing since you've made it a lot more simple?
So when we created this tool, and I still like the fact that I refer to it as quick and dirty, and you totally get that. That is the title I wanted to call it, but some very senior figures within NHS England just frowned upon that. But I still think if you explain it as that to responders, they know exactly what you mean. So what has been, I think, quite unique in the development of both the 10-second triage tool and the MITT is that we have field tested them extensively with a wide range of responders, looking at quantitative stuff, the time, the figures, how quickly can it be done? Is it done accurately? But also the qualitative stuff. How did it feel? Was it easy for you to use? And when we did the field test for 10-second triage, we developed what I'm quite proud of was a way of developing it. We created a mock major incident, and we had 40 odd patients within there, and it was a truly worst day of your life. It was a deliberate vehicle attack through a load of pedestrians, followed by a bladed weapon attack onto a bus, followed by some petrol bombs, followed by a person-born IED. So we had everything in blunt trauma, penetrating trauma, blast, ballistic burn. So we put all of those patients in. Rather surreal, but if you think about it, realistically to what we have seen, both UK and in Europe, in major incidents. And we put the first run of it, we used MITT just being done by ambulance service staff, and said to any police and fire responders there, just do what you would normally do. If you would do CPR, do CPR. If you would use a tourniquet, use a tourniquet, and just said, make it as real as you want. And within that 40 odd patients, we had a number of index patients that they based on real major incident patients from various events, Manchester, London, 7/7. And we knew they had a time critical life threatening injury that needed intervention. So when we used MITT on these 41 patients, we had live patients, mannequins that were alive, live patients that were dead. So you couldn't thin slice it, if you know what I mean. And we looked at the time to life-saving interventions, and it took the team of 10 healthcare people, it took them 20 odd minutes to go through these 40 patients and perform the life-saving interventions. So we use that as kind of this is our gold standard. This is how the current triage would be used. We then took the police, fire and ambulance, and we gave them education in 10-second triage. We gave them a lecture, we ran through some examples, and then we ran the same major incident, moved the patients around a bit so you couldn't quite predict where they were. We then ran a wave of police using 10-second triage, reset wave of ambulance, reset wave of fire, repeat as per. And we looked at the time to the life-saving interventions on these index patients. And the time to total triage went down from 26 minutes down to 6.5, 7 minutes. And we went, okay, so if you had a life-saving time critical injury that you needed a life-saving intervention, 22 minutes you are probably dead, 6 minutes you've got a fighting chance. But I think what was more powerful than that quantitative feedback was the qualitative feedback. So everybody was using the same language. It was as Jesset as you like. This is our tool. What is a P1 to you is a P1 to me, is a P1 to everyone else. They were going around, because 10-second triage is designed to be done as an individual, not as in pairs, but they were sharing equipment, they were sharing marking bands, they were sharing tourniquets, and it really empowered a lot of the non-clinical responders and also the clinical responders to say, I've done what is needed, I need to move on. And once that is completed, we will come back to these patients. And it was really powerful. They felt empowered and confident that they had done what was needed to be done for those patients in that initial period. And, you know, just watching the collaborative working was truly wonderful to see. Everybody just, you know, they got on message. So yeah, it was not only were the timings great, but the qualitative feedback and the buzz that everyone had from it was really, really positive.
That's powerful, actually, and as you say, you know, it's such a dramatic drop in time to triage, really. But has there been any challenges in adoption at all, Phil?
So I have to say, we had hoped that this would be adopted by all emergency services. And when we first started discussing this, that felt like a rather naive and ambitious idea. But when we presented it to National Fire Chiefs Council, National Operations Group from FRS, and we'd had a lot of FRS responders on the day helping out, they loved it. They bought into it. They said, we want something that we can use. We want to join in on this. Similarly with the College of Policing and the MPCC, they went, our staff needs something that focuses on life-saving interventions and, you know, can enable them to start saving lives. So they bought into it very quickly. The health sector bought into it, though. If you think about it from police and fire perspective, they never had anything before, or they may have looked at the NASMED tool and gone, oh, can we use this? So they were picking up something new, and so they adopted it very quickly. From an ambulance service perspective, you had this bit where you had to unlearn the old one and learn the new one. And we know what it's like when you get the change in the Resus Council guidelines. You know, you might learn the new ones, but it takes you a good 6 months to get the old ones out of your head. So I think the ambulance service took a little bit longer, but we're getting really positive response from them. What was then really moving was all the voluntary aid agencies. So British Red Cross, St John went, this is fantastic. It works for all of our responders, and all of the other UK search and rescue groups. So, you know, RNLI, Mountain Rescue, Lone Rescue, they all said, you know, this is great because we will deal with these instances well. We, you know, the austere environments that we work in, we want something simple. So inadvertently, the buy-in was much easier and much quicker than I thought it was ever could be, and it's really quite inspiring and humbling.
So just looking, you've spoken to a few case studies how you've kind of pressure tested almost the TST, and you've spoken to sort of that dramatic drop in time to triage. And could you speak, or maybe just emphasize slightly the feedback you have been getting from responders, from police and or fire and or ambulance services? It sounds like it's been really positive on the whole, and Could you maybe sort of just give us a sense of what, because like you said, the true test is actually when there is a real life triage scenario, major incident scenario, and this has to be enacted in reality. Could you maybe get a sense of just like you said, the qualitative data? Is there any sort of sound bites you were getting back from first responders?
Yeah, so a lot of the positive feedback we got on that field test, my colleagues in UK HSA Behavioural Insights team were fantastic at gleaning all of that, and that's just being published at the moment. That will be due out very soon, looking at that qualitative feedback. The enthusiasm with which responders took it. So we went, on that field test, we had 70 TST cards to hand out for people to use. I think we got 4 back. They all disappeared into people's pockets and just they ran off with it. They were really keen. As the training rollout has gone out, I'm picking feedback up from different areas around the country, and certainly I've seen it used in a couple of reasonable size incidents locally to me. We will never know until we have a true big incident as to how well this works. But what we designed for that kind of massive surge, that city room shock and awe when you walk in there as 2 responders and there's 300 injured people, what we designed for that we found was actually very quick and intuitive for that RTC with 5 patients, where you turn up as the solo responder or just a pair of you and you go, we're a little bit outnumbered here, but this is so quick and agile that it can be used on those. So we've had one incident where there was quite a bit of gangland violence and a lot of people injured by bladed weapons, and it was a very hectic and confused scene. We had police, public order police and firearms police and ambulance staff in the middle of the scene, and 10-second triage proved very, very effective at just getting an idea on those patients. And one of the bits we were always questioned on is why isn't catastrophic hemorrhage first? Why is walking first? Well, it's in there mainly because you want to thin down the numbers very quickly. People with true catastrophic hemorrhage seldom walk or not very far. And there is the common sense caveat in the tool which says if they look like they are bleeding, ask them to sit down and triage them. So we got some good feedback from that, but probably the most moving example I had was a multi-vehicle RTC that was probably, I'm trying to think how many vehicles, 5 or 6 vehicles. One vehicle had crossed the central reservation and gone head on into a number of others. And I think there was probably 15 or 16 patients. About 100 meters away from this incident was a police public order van with 6 public order people on there, 2 medics. They arrived on scene and they had triaged everyone before the first ambulance resource arrived on scene. And it was just incredible. So the poor ambulance officer who was first on scene came up and said, right, I need to get a handle on this. We need to start triaging. And the police sergeant said, don't worry, we've done them all. You've got X number of P1s, these P2s and these P3s. And it was actually quite funny to see what happened next, because it was like, oh, we've now moved much further through than you would anticipate. But we knew that all the life-saving interventions had been done. So it really does give you an ability to get a handle on what is going on very quickly. And the more it is being used, the more we will get feedback on it.
Listen, that's powerful for a number of reasons, actually, Phil. One is that, like you said, actually application within day-to-day practice. Practicing critical care, realized that actually treating these road traffic collisions as many major incidents actually was one of the best things to do from a situation awareness perspective. Because, like you said, more resources would come to scene. And there was this lack of shared situation awareness when there wasn't clear delineation of the priority on the scene. So priority 1, priority 2, priority 3. And then now to be able to democratize or delegate that out to an adjacent emergency service like the police or fire brigade, which might be on scene initially, again gives that common signature, and it almost divides the workload and it increases shared situation awareness, which both of which are absolutely fundamental to try to understand the priorities on scene, but also just treat the dead and dying. So to really start to understand where the priorities are. So that's powerful. I think that's
I think
powerful.
you're entirely right.
Yeah.
Uh, so you're entirely right there. And if you think about it, any large scale incident that we attend, it is about bringing some semblance of order to chaos. And if you've all got one tool that you all share, and in delivering it, you are providing the life-saving interventions, all of a sudden that gives you that very quick grip on what is going on. And you're entirely right. It's then you just go, okay, I now know the key basic bits have been done. Let's use my clinical skills and acumen to focus on what comes next.
So just looking at and moving on slightly, just to look at what comes after the TST. So the major incident triage tool. Phil, could you maybe speak to how it integrates within the broader MITT triage process, and indeed maybe more of a comprehensive patient assessment?
Yeah, so I think if we embrace the idea that we will use TST on any incident where we are feeling outnumbered, so that may be something truly massive, Manchester, London Bridge, something like that, or it may be just something like that, those two cars head on somewhere in a very remote and rural location. Once you've used 10-second triage, you have prioritize your patients into your P1s, 2s, 3s, and silver, not breathing. I think the next big decision that comes is this of such a scale that I now need to go into the major incident triage tool, or is this of a scale that is manageable that I can just run as business as usual? Are more resources with me now? And I think that really is an operational command decision, usually with a senior clinician involved, whichever is the most senior clinician you have on scene, to decide, do we need to instigate MITT, or can we just run this as business as usual? Because ideally, we want to give the patients the standard care they would have if they were the only patient. So if you can manage it as business as usual, do that. So I think that's the kind of command decision from the individual clinician's decision making. I think the two bits for me are, once you've got 10-second triage done, you will have some P1 patients, and you need to find the true time critical ones within that P1 patient cohort and get them moving off to definitive care. Rather than using all of your staff to fill up functional roles, you need to start thinking about the patient's need. So I tend to turn, you need to go around and find the P1iest of the P1s in there and get them moving off to hospital. And that really is a clinician's decision. That isn't necessarily for our emergency service colleagues to do, because we have done the bit that has highlighted them as P1. So that would be my first priority. My next priority would be to take a clinician and go round those silvers and decide whether they are truly dead, and you can take your time and do formal verification of death, and then that will be dignified. It will be done in a much more calculated and timely way that can be justifiable both for yourself as a responder and come whatever legal scrutiny happens. Or within that silver cohort, if there is perhaps just one of those and a number of not too badly injured patients, maybe it would be appropriate to deliver the ultimate level of care we would do anyway. So a lot of that, I think, really comes down to, you can only make that decision once you know the entire scope and enormity of the scene that you are dealing with. So until 10-second triage is done and completed, you don't want to be making those decisions. But the two key bits are, find the P1ist of the P1s, reassess the silvers, and that's focusing on the patient needs.
So just looking, Phil, for a second at the training and familiarization that's currently required for emergency services and a broad perspective, to adopt the TST effectively, what's the training and familiarization package look like at the moment?
To a degree, that depends on different organisations, and I think it should also depend slightly on the responder group. So we found out that even with no training, if you just hand that triage algorithm to a responder, because it is so simple, they can use it with no training. I would not advocate that. I would always be wanting some training. I think there should be a degree of either lecture-based or online training, and then work through some worked examples of different patients and say, okay, what triage category do you think this one is? What triage category do you think this one is? What life-saving interventions do you need? And my colleague Sean Harris from London does some lovely work on, there are cognitive shortcuts to 10-second triage. So if you have intervened on a patient, you've done an airway maneuver, a hemorrhage control maneuver, put them into the recovery position, they're a P1. So that's your shortcut tip. Because I do a lot of work with critical care teams and hazardous area response teams, I like running triage trails. And because the more you run live patient or mannequin triage trails, the quicker and the slicker you get. So for people that are in roles that there is a high likelihood that you will need to be triaging a large number of patients. You'd need to invest more time in the education. But, I think if you take 60 minutes of education, you can make people very good at using 10-second triage. But this shouldn't just be once and never again. This just needs to be repeated, small little doses over and over again. And it's dead easy to run a little triage trail in a crew room. You can do it from video snippets, you can do it from pieces of card, and just get yourself into that idea of, okay, I want to run around all these patients. We saw that when we did the field test, that the emergency service groups, got a little bit competitive about how quickly they could triage patients. And I want to put a little bit of that competition in there to show it is quick and easy. If you're looking for information on the education of it, College of Policing will be developing theirs. National Operations Group for the fire are developing theirs. There's stuff on the NARU website around how to educate it. But, go out and make up your own little bits of education to learn how to use TST.
Yeah, that's fantastic, actually. And like you said, there's multiple applications, but also the beauty of it, and because of the simplicity, is, like you said, there's varying levels. But even just from broad brush introduction to, like you said, kind of more kinesthetic, real life, actual application of the tool. Because as you said, actually getting your hands on patients, albeit dummies or even mock up high fidelity simulation with real life actors, either way, it's you forcing interaction with the tool, and it's that sort of kinesthetic learning which really you can sort of leverage for real life, which is fantastic. Just looking at the potential challenges or limitations, Phil, for emergency responders using TST, is there any mitigation strategies that you would advocate sort of regarding any limitations?
So I think one of the bits that has come out quite elegantly within TST, you could use TST as a first responder. With just basic first aid skills, stopping the bleeding by direct pressure, maybe using a tourniquet, improvised or otherwise. You could use it as a reasonably well-trained police medic, where you may have more in your kit bag, like hemostatic gauzes, airway adjuncts. You can use it as a paramedic, as a doctor, as whatever, but it is still the same basic algorithm. The interventions that you might do might be a little bit different because you have more kit in your bag. I think one of the areas that we need to be cognizant of is we changed the catastrophic hemorrhage decision node to be severe bleeding, because if you look at evidence certainly from Manchester, from John Harrison, the the severe bleeding was not recognised as catastrophic hemorrhage. And, Sir John Saunders' public inquiry, looking at that case, there is, that is probably the only one in whom a life could have been saved if life-saving interventions had been done in a timely fashion. What we need to try and enable is for people to recognize severe external bleeding and treat it. And I think there then becomes a bit of a difference. For those of us that are clinically experienced, we may look at that and go, that's not too bad, but a lay responder may say that is severe bleeding and treat as a P1. So I think in people who are less experienced, there may be a tendency to over triage towards P1. But I don't mind that, because clinicians will follow that up, and clinicians will then be able to go, okay, I see why you did that, but all this needs is addressing. So I think we need to be cognizant of that. The senior experienced clinician coming in after 10-second triage is essential to make sure they get the right treatment. The one bit that TST is very good at is picking up those with penetrating torso injury. So we were very cautious about saying, root of the neck, front of the chest, front of the abdomen, down into the groins for those junctional areas, axilla, buttocks, anywhere where you could prang a big vessel with incompressible hemorrhage that may, be making this patient time critical, and we can do very little about that at scene, particularly in a large scale incident. So it is very sensitive and specific for those, but it will not pick up those who are shocked from blunt trauma quite as easily as if when you were using physiology. But once you've done 10-second triage, you come along and somebody will be doing physiology, be that in the MITT or in part of just standard care. So we will be able to pick those ones up. So we're using for physiological shock, we're using surrogate markers of inability to walk and inability to talk, which I think are valid in that quick and dirty stage, but they are not valid for later on.
So just as we start to come into land, Phil, a couple more questions. One would be just, could you maybe speak to how you've seen adoption and or interest on an international level? Has there been any international engagement with the tool?
So it's been fascinating. One of the things I've learned, having looked at triage tools for quite a while, they're like toothbrushes. Everybody agrees you should have one, but no one wants to use anyone else's. So it's been fascinating when we've taken TST and presented it at international conferences. And initially there's been quite a bit of, oh, surely that's too simple, we must have something that is better. But then when they've seen it in action and either their own little exercises or they've thought it through, people are really going, that is just so quick and dirty. People are starting to quite like it. The Lebanese have been very keen to adopt it after the tragedy they had at the explosion at the port. They found that the NASMED tool didn't work. There's a number of Scandinavian countries that are looking at it. The Portuguese are looking at it and have asked me to go over and present over there because they're keen to have a unified tool for all of their responders. And I was over in Paris recently and discussing it with the French, and people are now kind of getting the idea that this isn't the answer to everything. It is that initial quick win. And when I discuss about triage tools, I give people the analogy of, do you want a Stone Age axe or do you want an operating robot? A Stone Age axe, anyone can pick it up and use it. One's a handle, one's a hitty end. An operating robot, very sensitive and specific, but takes months to learn how to use, hours to set up. So in that early stage, something quick and dirty that is very easy to use. So I'm seeing a lot of international interest. A number of states in Australia are keen to adopt it. So yeah, this thing is growing fantastically.
Oh, that's fantastic to see that, and like you said, I think the adage is far more reaching, wide-reaching than just the UK for this tool. And so, just a final question, really, Phil, and that would be around educational material. I know you said there's going to be a number of things popping up from the UK Police, and indeed maybe the Nauru website. But where would people go if they want to find information at the moment?
So if you're looking for information, apart from your great podcast, and other podcasts are available, I'm sure. Uh, the NHS England website gives you the basic information on the MITT and the 10-second triage, and we were very keen that the NHS kind of hosted that. If you go onto the Nauru website, there is some videos there for both, first responders and for healthcare responders. And there is also a lot of frequently asked questions on there, which gives some of the nuance into those bits where people ask, so, what about chest seals? Should we be putting chest seals on, which I keep getting asked? Well, the answer is they take time, and we know chest seals stick to two things principally, gloves and themselves, and they don't stick to the patient very well. And the chest seal is not a life-saving intervention. Recognize the penetrating torso injury. If they've got an open pneumothorax, get somebody to put a hand on it, move on, finish triaging, then come back and do that. So if you go onto the Nauru Education website, there's lots of bits about the how to teach it, some videos, and the frequently asked questions, which will really help if you want to get an in-depth bit. We've had a couple of scientific articles come out regarding the philosophy of why we started it. We've got the work coming out from the Behavioural Insights team looking at the qualitative feedback on it. And yeah, there'll be more publications coming out very soon around the timings and the benefit in time to life-saving intervention.
Well, that's fantastic. And we'll put those links in the show notes actually, because it'd be great, like you said, just that people can do a deep dive and just look at the spectrum of information which is out there. So thank you for that. It just leaves me to say thank you, Phil, for the last 45 minutes. It was fantastic just to pick your brain and have just your perspective on the progression and fruition of this tool, which has been really, like you said, the adoption's been fantastic, but the battle testing as well and the application. So, but thank you so much for the last 45 minutes.
No, thank you, and I think it's just a massive thanks from me to the team that helped create this. This was myself, Claire Park, Jamie Vassallo, Sean Harris, Dave Ball, Jason Smith. We all just sat down and came to it from slightly different perspectives, and it came together really well. And I'm really grateful to NHS England for supporting it. It's been 2 years of hard work before we got to the point of being ready to roll it out, and it's still being rolled out now, and it's fantastic. But I think it will save lives, and certainly that was the view that Sir John Saunders had in the Manchester Arena inquiry. He felt that if all responders had this within their skill set, that potentially lives will be saved at a later major incident, which is, we want the memory of those that tragically lost their lives to be taken forward to prevent future deaths.
Yeah, I think ultimately, Phil, that's what everyone's in this for. Like you said, prevention of future deaths and indeed fundamentally patient care. And as you said, it seems to be in the research and indeed in the high fidelity simulation where you're testing it, seems to be not time to triage, but time to understanding the hierarchy of priority, hierarchy of clinical priority is absolutely being improved, which is leading to more preventable deaths and really leveraging that. So it's powerful, absolutely powerful.
Yeah, and I think that goes back to why are we there? We are all there for the patients to save those that can be saved, and for something that crosses all emergency services boundaries, that focuses on saving life, has got to be a great thing. And I think trying to reframe our approach to the management of large scale and complex incidents, and stop thinking about what each emergency service does and what they bring in the system. If we just focus on what does the patient need, who can deliver it, let's get it done, will be a fundamental change.